IgG4 disease, one of the hidden disease, one of the most chaotic disease which could actually involve all of the organs. That is, the multi-organ involvement could be there. Hello everyone, I'm Dr. Achla Hengde, and today will be having a short topic IgG4 disease discussion, which could be involving all of the organs, most of the organs actually, and it would be a short topic. And I hope you people enjoy this video. So let's start with this IgG4 disease. Now, what is the IgG4 disease? Now, many of us have come across this terminology, but actually we haven't diagnosed any of the disease, any of the condition like this before, unless in early 2000s and the people started publishing the articles and we got to know about this disease. Okay, so this is kind of a new disease, we could say, and it has been included in rheumatology. Okay, so it is actually a lack of complement binding that is seen in this disease. Okay, now and there would be anti-inflammatory properties which are involved in the IgG4, which is actually we can see there is this IgG4 molecules. Okay, and there is the light part and the hinge heavy part. Okay, and what happens is this is the fab arm exchange that is there. Okay, and there is this because of the fab arm exchange there will be sequestration of the antibodies, and thus there won't be any immune complexes formed. Okay, now so what happens is this will be causing a new bispecific IgG4 molecules. Okay, and this causes activation of myofibroblast, that is causing platelet derived growth factor and the tissue augmentation of the fibrosis, which is causing the storiform fibrosis. Now this is an MCQ. This has come multiple times. What is the hallmark, or we could say pathognomic features? That is the storiform fibrosis. Okay, now coming to the case-based scenario, the interesting part is this is mostly occurring in a postpartum female, which is actually one of the manifestation for her. Now what happens is the patient will come with the headache. Okay, and we could think that it could be one of the CVST, one of the most important cause. Okay, or it could be a press, right? So we could think of all these things. Okay, but none of us will think it could be one of the IgG4 disease. Yeah, so we go with the MRI first. Okay, and on the MRI we find a mass. Okay, and so with the help of the surgeon we remove that mass, and when we do a microscopic analysis, we find there will be a lymphoplasmacytic cells. Okay, so that is something which is will give us a hint that it would be a IgG4 disease. Now, this has a very good response to the steroids. One of the major important thing to understand is we many a times this is actually a hidden disease. So many a times in an autoimmune disease, or whenever we suspect any of the in females mostly we suspect autoimmune disease, we give her a steroid and she would improve drastically. So unless and until you perform a biopsy, we could actually not say that it is a IgG4 disease or it is something else. So this is something which is a diagnosis of exclusion. Remember that. Now, so there is one more thing which is important, that is a obliterative phlebitis. That means there will be occlusion of the veins by a lymphoplasmacytic cells. Now this is very important, that the lymphoplasmacytic cells are very much raised in this disease with that of the mild eosinophilia. Okay, so there could be one of the thing is the background of atopy or a certain allergy could be there. So there would be spectrum of diseases which could be there. That is a type 1 autoimmune pancreatitis, then Nicholas disease. Okay, then there could be primary sclerosing cholangitis, retroperitoneal fibrosis, Riddle's thyroiditis, and lymphocytic hypophysitis. So I know most of us we have heard all of these diseases. Now, mostly it is a common in males, which is more than 60 years of the age group. In females, postpartum people can have such disease. Okay, it is actually a subacute presentation, and of course there would be a background of atopy or allergy. Now the constitutional symptoms are very common, but remember, when it comes to an IgG4 disease, fever, arthralgia or arthritis, this is never seen. Okay, this is never seen. So if the question says patient has a fever, patient is a 65-year-old male with the saying that 10 to 15 days he has a history of fever, arthralgia or arthritis, please rule out IgG4 disease. Okay, there won't be any fibrinoid necrosis on the biopsy, no granuloma formation as such, there is no ANCA or there is no ANA as well. So when it comes to manifestation, one of the major thing that comes to our mind is the type 1 autoimmune pancreatitis. This has to be kept in mind when we are talking about IgG4 disease. Okay, the next thing is major salivary gland involvement, lacrimal gland involvement, and there could be a retroperitoneal fibrosis as well. And the minor things are the other organs that could be involved. So let's see one by one what are the things that is important to us. You could see this image. So this person is having a mass, okay, which is actually a non-tender, which is symmetrical, okay. It is mostly the submandibular gland which is involved, okay, and it is painless, and it is patient may be asymptomatic, and Zika symptoms are not here, so that can differentiate between the Sjogren's and this. And this has a response to steroids, whereas the Sjogren's do not have response. Like Sjogren's involving the salivary gland, they have poor response. Okay, so that is the difference. So it is the parotid gland which is involved here. It is the submandibular gland. Then Zika symptoms are more, and it is not responsive to steroids. Okay, so now when it comes to the lacrimal gland, it is symmetrical again, but it is painless, okay, and it is asymptomatic. Then retroperitoneal fibrosis, okay, so there would be a lower urinary tract symptoms because of the obstructive feature, okay, and there will be obstructive uropathy, and there will be of course a decrease in the urine output, and this is also subacute only. It is not an acute retention of urine. Then coming to the pancreas. Pancreas is the most important thing. There will be a type 1 autoimmune pancreatitis. There will be something which is sausage shaped pancreas could be seen, like in this image. There is a sausage shaped pancreas because there is this enlargement which is there. So diffuse enlargement of the pancreas, which will cause narrowing of the pancreatic duct, and that will cause obstructive jaundice. So patient can come with the jaundice, and you have to think of whenever there is increase in the ALP, straight away think of MRCP or ERCP, whatever you have in your institute. Exocrine insufficiency could be there, and endocrine we have diabetes, which could be appreciated in such patients. Okay, the next thing is vasculitis. So that will be uveitis, okay, as a vasculitis. Then orbit, or whenever the orbit is involved, it is something which is very painful, and there will be a mass. So it is inflammatory, and there is a pseudo tumor like condition, that is a mass, okay. Then the CNS, we have lymphocytic hypophysitis. Now we have seen a patient postpartum raise ICT, like nausea, vomiting would be there, neck rigidity could be also there. So raise ICT signs could be there, and pachymeningitis could also be appreciated in certain conditions, certain individuals. Then primary sclerosing cholangitis. So there would be a fibrotic lesion of intra and extrahepatic bile duct. Okay, I have made a detailed video in primary biliary cirrhosis. You can just watch this video. What is the difference between primary sclerosing cholangitis and primary biliary cirrhosis? Then the lung. Lung, we have a NSIP pattern. Okay, and thickening of the bronchovascular bundle could be appreciated. In the kidneys, tuberointerstitial nephritis, that is they have a response to the steroids, CTID I'm talking about, and some conditions, some people can also have membranous nephropathy. Okay, so now we go with the IgG4 levels that is increased, okay, which could be actually considered as a marker for disease activity. Okay, then this ratio is very important. Please remember this ratio, which says IgG4 to IgG ratio, which is more than 40%. Okay, and of course you have to go with the biopsy so that we could say a plasma lymphoplasmacytic cells. Okay, now the treatment is we have to go with the steroids, and if the patient is not responding, obviously a rescue therapy of rituximab is tried. Okay, so that was all about the IgG4 disease. Thank you so much for watching.